get started with the panel. The panelists should probably introduce themselves first.
I'm Sydney Russell-Lead from SUNY Upstate Medical University, talking about the New York Health Act.
My name is Wendy Coard. I'm from the University of Washington. I'll be talking about current Washington bills.
My name is Michelle Lee from UCLA, and I'll be speaking about the Healthy California Act.
And my name is Robertha. So the first question is, tell me about your state single-payer bill.
So I mentioned this earlier today during the single-payer update, but the New York Health Act is pretty similar to Jayapal's federal level bill. It includes all medically necessary care, including vision, dental, mental health, reproductive services, and long-term care. Guaranteed enrollment, guaranteed choice of physicians and hospitals. The plan prohibits for-profit insurers, but allows for-profit healthcare providers, which is something we don't fully support, but it's what we're working with. And the option is not public, sorry. The plan is not public option, it's a true single-payer system.
So there's currently 4 pseudo single-payer bills in Washington right now. We have or 3, I guess. We have the WIST, which is the Washington Health Security Trust, that has been, it was introduced back in like 2013, and it's kind of been sitting there, reintroduced every year, and it hasn't really moved at all. It kind of establishes a security trust that's going to be managed by a board of people, so you establish a work group, and the point is to be all-inclusive, to have everyone be able to access a standardized plan. However, the biggest thing that it's lacking is that it doesn't include people who are already taken care of by Medicare, Medicaid, Indian Health, or any other federal assistance are able to stay in their plan, which is one of the why it's like a pseudo single-payer bill. Currently, we also have the Cascade Bill that some people are kind of naming it. It's the Governor Inslee bill, which is mostly just expanding the individual market to make sure that people who fall in between the ACA coverage and the individual market are actually able to access a standardized plan. And the bill really just establishes a workforce to kind of implement optional plans in the individual market. So it's nothing that, there's no part in the literature that will allude to comprehensive or details of how comprehensive the plan has to be thus far. The last plan, which is a pathway to universal health care, is basically creating a work group, and that's one that's actually been pretty active right now this year. It's creating a work group so that Washington State can be prepared and ready for when we have federal allowance to use that federal allotted money to implement a single-payer system in Washington.
So Sydney mentioned this in her earlier talk, and she mentioned that SB 562, which is also known as the Healthy California Act, was not actually passed. It was shelved, and then we currently don't have a bill, so I'm just going to talk about SB 562, which is our last bill of reference. It's a pretty comprehensive system that was proposed. It would cover a lot of inpatient, outpatient hospital services, all medically necessary needs. That includes vision, dental, reproductive, mental health, and there would be no out-of-pocket payments, including like deductibles, no premiums, any of that. And in addition, they would be run by the Healthy California Board, and under that, they would have a member from a labor organization, an individual from the registered nurse, an individual from the healthcare organization, also someone from the general public. And this healthcare system would also cover any resident of California, regardless of immigration status.
Just so that you know, so we're going to go through questions that we already have at the end for audience questions. So the second question is, what is the current status of the bill, and what is the likelihood that it will pass in the current session?
So the New York State legislation has two bodies, the Assembly and the House. The Assembly is a lot more liberal but less powerful. So they strongly support the New York Health Act and have passed it the past 4 years. So there's a lot of support there. The Senate in the past has been mostly Republican. That changed this year, so that's really optimistic. We're optimistic about that. We had a lot of Democratic state senators last year support the bill, but at that time it was more of a symbolic gesture because the state Senate was Republican controlled. There was no way that we could actually pass the bill. So a lot of people who supported the bill last year are now kind of taking a few steps back. In order to pass the bill, we would have to pass it in the Health Committee, then in the Finance Committee, and then through the General State Senate. So the Health Committee is chaired by the co-sponsor, the original sponsor of the bill. So that is great, but once it passes through the Health Committee, then it's kind of stuck in Finance, and the chair of the Finance Committee has been less optimistic. She was a co-sponsor last year and is now kind of backtracking a little bit or being skeptical. So it's possible, but unlikely that it would pass this year.
So for the two, like the WIST bills, the WIST bill that are in the House and the Senate, it's kind of been very stagnant since 2013. A lot of even the new Democratic seats that we got over the last elections, even they have not really been sold on those specific bills. I think the biggest issue with that, like I mentioned, is the wording about funding the actual trust, and those logistics are really something that really prevents people from moving on with it. So we have not really been very optimistic about those bills moving anytime this session. However, there's been a lot of movement for the Cascade Bill and the universal pathway, or pathway to universal healthcare bill. Actually, I was just hearing, the hearing was like this Wednesday, and they're both just moved onto the Rules Committee, so a Rule 2 committee. And there's a lot of momentum for that being, for both of them to pass actually through that committee.
So the Healthy California Act was last amended in 2017, and it passed the Senate actually in July of 2017, but was shelved by the Assembly. And the Assembly Speaker, Anthony Rendon, actually said it was incomplete in terms of finances, delivery of care, cost control, et cetera. And he cites, although Anthony Rendon does claim that he is a supporter of single-payer health care system, he also does pocket over $400,000 from healthcare, the healthcare industry. So I'm just going to leave it for you guys to decide, like, if that played any role in his decision to shelve the bill. But right now, as was mentioned earlier, the bill has been shelved. There isn't currently a proposal for a new bill, but we're envisioning that they would have to scratch that and completely form a new one that is probably similar to the Healthy California Act.
Next question. How popular is this bill throughout the state? Are there some cities that support it more than others, and why?
I'm not sure of the numbers in terms of popular support, but I know that most people that I've talked to who know about it love the idea, but not that many people know about it. So when we go out canvassing or tabling, people don't really, they haven't heard of it, they don't understand what it is or why we're advocating for it. I think, so I'm from upstate New York, which is a much more conservative area. I think downstate in New York City, there's a lot more support for it. And upstate, at least in Syracuse, but I think some of the other major cities upstate are like this as well. But Syracuse is a post-industrial city that has seen a lot of job loss, and now the main employers are hospitals. And so the opposition to single payer is kind of taking advantage of this and saying, like, the only things that you have left are hospitals for job opportunities. So if single payer passes in New York State, then there will be fewer hospitals and fewer job opportunities, which we know isn't true, but it's been a way of targeting these low-income cities.
In regards to Washington, I also cannot give you complete numbers because every poll that's been presented, it's either very localized to pro single payer or very localized to against single payer. But overall, there's a huge movement that's positive and reinforcing the movement towards a single payer system within the Washington state and in the nation. There's a lot of momentum in the West Coast to promote it. A lot of people are aware of it and they support it. I think the biggest groups that we have is Eastern Washington, which is predominantly rural and small town. A lot of them are posted mostly because of the ways that it has been alluded to implementing a single payer system has been with increased taxation, which is something that affects them and small businesses in general. So I think a little more of education is what we focus on. In the West Coast, same thing for mostly lower SES people who want a universal coverage, but they are unsure about how a single payer system will affect them economically is the biggest obstacle. So, but there's a lot of movement and a lot of, I would say the majority is pro a single payer.
Very similar. In California, it's very liberal, so a lot of surveys show that over 2/3 of the population is actually in support of a single-payer healthcare system. And our new governor, Gavin Newsom, is also highly supportive of that. In addition, I'd like to bring up that our junior senator, Kamala Harris, who is announced her candidacy for the upcoming election, also announced that she will be co-sponsoring Bernie Sanders' Medicare for All. So I think overall, California, especially the larger cities like San Francisco, Los Angeles, and San Diego, are in support of a single-payer healthcare system.
What involvement has your chapter had in regards to advocating for your state's single-payer bill?
Our group in Upstate has mostly been focused on outreach and messaging. We've met with legislators, we've met with the editorial board of a local media outlet, and we do a lot of canvassing door to door and collecting people's stories, talking to them about their experiences with health insurance and what they'd want to see change. We also did some voter registration with the NAACP last year, and that was a good partnership because the members of the local chapter of the NAACP hadn't heard of the New York Health Act, so we were able to help them with their voter registration outreach while also talking to them about this bill that they weren't as familiar with. Other chapters have done city council resolutions. Syracuse has not, but we should. And then op-eds as well, something we're working on. Our lunch talks on campus are usually state-focused rather than what single payer would look like at the federal level. We try to focus pretty specifically on the state bill and what's being done on the state level. And our chapter on the e-board, we have community liaisons who are expected to attend meetings of local organizations working for a state-based single payer.
I just wanted to point out that we have tried to talk to the city council and they just keep pushing back the hearing for it. So we've tried.
For Washington State, our chapter is relatively new. So one of the main things that we keep going and we kind of started with is doing a lot of town halls, a lot of events where it's more of an educational and it's open to the community. So we do a lot of outreach to the community to give them an understanding of the current healthcare system right now and what they're paying, where their money is being allocated, and then give them insight into what a single payer would mean for them. Some of the things that we started kind of doing more now is getting involved in the statewide movement. So we've actually started establishing rapport with different offices, like the office staffers for Representative Pramila Jayapal, who introduced the bill. Everyone should probably know about that bill, right? So we do have built relationships with staffers there, and we want to keep continuing building those relationships. One of the things that our talks with them have told us is that it's always very, very quiet and nothing moves until everything just goes. So having your ducks lined up is what we're trying to make sure that we know how we can support the system when time comes. Other things that we do is we're working on a letter, which we were hoping to do it at an institutional level, have University of Washington just be we support single payer because it's like the largest medical school in that region. However, we got a lot of pushback from that. So we're working on actually grabbing individual faculty members who we know are kind of leaning towards the cause and having them spread the letter to their colleagues, more faculty members. Unfortunately, we got a very hard no in terms of using UW medicine as part of the people who signed it, but that's what we're working on right now.
So for UCLA, our chapter was recently restarted, and we're starting off with a series of talks about the single-payer healthcare system. Basically, we're just trying to spread the education for all the students on campus and getting the information out and building a strong network. And in addition to that, we're also working to collaborate with SNaHP chapters at UCSF and also USC to create a steering committee where we can plan for bigger projects and just build a bigger support system and network.
How do you think a state single-payer bill fits into the fight for a national health plan?
I think we have to prove that this kind of system works in the U.S. on a state level before we'll see it on the national level. That's what happened in Canada, and I think it's going to happen in the U.S. as well. What was I going to say? Oh, I also think that once New York or another state has a single-payer system, they'll be able to collaborate with nearby states and increase their bargaining power and risk pooling with other states, so it kind of has this domino effect. That's how I see it.
That's kind of like the same thing I had in my notes, to be honest. Canada does provide a very clear illustration of how things starting at small, like at the Providence level, kind of amounted to the kind of care they have at the national level now. And again, the same thing, I think once we get it going and we get it working correctly as it's meant to be working at a state level, that's going to really implement more momentum for a national level. I think also the one thing we should watch out for is not implementing this right at the state level is going to keep feeling that fire of the opposition to just kind of say well, it didn't work in Vermont, it's not working in Washington, especially for the states that are very liberal and very progressive. Messing it up at that point is a huge point against the single payer at a national level. So states like New York, California, Washington, I think it's up to us to really make sure that when we implement it, we do it right and we do it as intended.
Piggybacking off what Sydney and Wendy said already, I think it's really important if California starts at a state level, other states will want to follow. Not only is California the biggest, most populated state, it's also the 5th largest economy in the world. Last year, I don't know how many people knew this, but it even beat out the UK. So if it works out in California and people see that we're saving money, people are happier with this single-payer healthcare system, then other states will also want to follow suit.
Last question kind of goes along with what we were just saying. What have you seen go wrong in the push for a state single-payer bill?
I think in New York, one of our biggest challenges is the lack of diversity and a lack of coordinating with other campaigns that have the same or similar goals, and not really seeing how single payer fits into a broader movement for health equity and health justice. And I hope that's something we can talk about today as part of this session and later on.
Definitely agree with that. Things that I have specifically seen it in my state is that our bills are not true single payer. And the issue with that is that we already have to fight against the opposing parties. We end up having to also struggle and fight with the parties that want true single payer. Because when we introduce a bill that's pseudo single payer, they don't want to back it. They have a lot of amendments that go through and then they have to be re-evaluated every time. So it just makes the struggle even worse. The other thing that I noticed, we try to kind of bypass the legislation and do an initiative so they could just go straight into the ballot. And money has been such a huge issue for that. Money is the issue across everything. It's how we're going to fund single payer, how are we going to fund advocacy for a bill. The initiative 1600 that we had last year completely failed. We got 100,000 signatures, but we needed 250,000. And the reason behind it is I don't think that the campaign behind it was Whole Washington. I don't think that they realized how much time it would take to gather those signatures without the money to invest in paid in paid people who are signature gatherers. We were based off of purely volunteers who would take their time and do it. So kind of evaluating those things is like really important.
When I think about negative pushbacks, I think like number one, self-interest. I mentioned earlier, our Speaker of the Assembly was pocketing like $400,000 from healthcare industries. On top of that, our former governor, Jerry Brown, was pocketing almost $3 million. So there's a lot of self-interest involved. A lot of pharmaceutical companies are like present and they have a lot of power. And on top of that, I also think about what people think about when they think about single payer. I mentioned earlier that about more than 2/3 of California residents, when surveyed, said that they were in support of a single payer healthcare system. But when they find out that that might mean higher taxes, then less than 50% are in support. And yes, there will be higher taxes, but it's also important to spread information about how that will impact people. When they did the survey they know that we will be actually saving over $37 billion. And yes, tax will increase, but people will end up saving money because they wouldn't be having to pay for out-of-pocket costs anymore. Employers are saving money because they no longer have to cover insurance for their employers. So there's just a lot of different information that needs to be getting out to people.
Okay, that was the last question. Could you just thank our panelists? If they didn't do that. We want to open it up for questions.
I know you mentioned like having a true single-payer system rather than a pseudo one, and I think if we look at different countries with single-payer systems, they all look different. And I think one challenge that passing this on a state level could be that each state has their own version of single-payer that looks different. How do you think that transition from state to national single-payer would happen, or what the challenges are in light of those things?
So I think that's a really good point that you bring up, and I think that's what one of the things that when we bring up with our Physicians for National Health Program parent organization, one of the things that we kind of debated last year in 2017 is, do we put our effort into state or national? Because if we do the state thing, everyone's gonna have a different state thing, and then how are we gonna keep pushing the national? Everyone's gonna have their own little like weird system, and I think one way to counteract it is like the intent of a federal national single payer is that whatever committee encompasses the task of establishing that standardized plan, it will be implemented to all the states. In terms of funding, a single payer system is the solution because it doesn't matter where each state is paying their single payer. Once they have the funding from the federal government, I think that'll really alleviate a lot of the stressors that come with the intricacies of like establishing at a state level. I don't know if that makes sense.
I think also if we're strategic about the baby steps that we take towards national single payer, we can kind of set ourselves up for an easier transition. Like one of Jayapal's bills, not the federal one, but the one that would make it easier for state-based plans, increases states' ability to use federal money for state-based plans. So although using that bill, if it passes, each state might develop their own system, which would be difficult to integrate, yes. Having that kind of federal level support, I think, would ultimately make it easier to have the different systems come together in the end. There was someone behind you.
On the topic of state level and backing state level plans, my understanding of Canada's success, it started with Saskatchewan, I think, was that when they were faced with the almost killing stroke of brain drain, physicians leaving to be paid better in the US, was that there was a loophole that allowed British physicians to come practically overnight and start working in Canada to fill that gap. And we don't have that here. Are there plans in place to mitigate that?
So I don't know if this answers your question directly, but I did, yesterday when I was doing research for the presentation, I saw a graph that showed that doctors were actually coming back to Canada after they implemented nationwide.
That's after they were able to see that it was self-sustainable.
Oh, okay.
But it needed British physicians to come and help in the long term, or the short term.
Oh, okay. I wasn't sure if I answered. Okay.
I'm not sure, I'm sorry.
I'm a little bit unclear. So you're saying how we're going to overcome the migrate?
Place to mitigate brain drain. If it's passed in California or New York, what protective factors might there be when physicians decide to go to another state that will maybe pay them 20% more?
I see what you mean. Yeah, I mean, that's a really good question. I think that's something that one of the things that we should probably address is included. So one of the bills that I mentioned for Washington particularly includes establishing the work group to be ready for a state plan. One of the things is to have representation from physicians, from hospitals, from insurance companies, and patients, community advocacies, like members and stuff like that. And I think that's one of the things that will be brought up, or from talking to people who have been working on this legislation for a while, that's one of the topics that have been brought up, along with how this would hurt establishing your own private practice, especially in small towns in Washington, how they're going to pay for supplies and things like that. So those topics have been brought up, and I think that would be up to the workforce that's made in each legislation. Every bill has there will be a work group that will deal with those kind of things, those kind of topics. So, yeah.
One of the commonalities in international single-payer systems in Canada, UK, and even in Germany is a national healthcare price limit set by the government for basic services, extended care, etc. I'm not sure in depth on what level states are initiating those hard limits, if they're currently being talked about, and then what steps are being taken to control medical tourism from outside states to take advantage of those much lower prices.
I think those are two of the most common criticisms of state-based plans that I've heard, and I don't have a good answer for either. But I know there's a lot of New Yorkers in the room, so if any of you, I'm going to crowdsource this, if any of you have solutions or know of ways that we're trying to tackle this, feel free to raise your hand, jump in.
Also, to be clear, I'm not criticizing. I'm just really curious if we're
I
going
mean,
to implement
they're
this.
very legitimate issues that need to be worked through that we don't really have an answer for.
Sure.
Yeah.
And if you're asking a question, can you make sure to hold the mic pretty close? Because I think people in the back are having a hard time hearing.
Thank you. So my question is, would the state-based programs become obsolete with the passage of a single-payer system on a national scale? And if that's true, could they potentially stand in the way of national reform? Thinking of systems like how fragmented Medicaid is, serving as a barrier to getting a nationwide program up and running. And then my other concern is, and kind of in line with that, how do you respond to some that might be concerned that the energy and effort you put into state programs could be wasted, especially if the risk is high in, if it were to mess up like it did somewhat in Vermont, kind of bringing a bad name to single payer. How do you respond to that?
So I think that's like one of the biggest issues that happens when we speak about state versus national. And one of the reasons why I personally really like the Universal Pathway Bill, or the Pathway to Universal Care Bill, I keep saying that wrong, is that it kind of creates a group of people who will figure all of that out, hopefully, or figure out a way to implement a state-based system that will not prevent a transition to a national system. I think that's probably like the best way to do it. Make sure that when you're implementing the state-based single payer, that you are aware that it will be a smooth transition towards a potentially single payer national system. And I think that's one of the big issues that the WISP has not gone through, because it's not a fun way to implement universal coverage, and it still has a lot of different people paying for different parts of the care. So, but that's a really great point.
I completely agree. And also, in addition, I feel like even though there may be differences on state levels, our common goal is the same. So that would be really important for the transition to like a federal level single payer system.
You mentioned the energy of organizing for state-based single payer, and I think the education and outreach that we do is applicable to the national single payer as well. So if we can't get state-based single payer, we say, okay, we can like offer you something better, you know? Like it carries over into the movement for national healthcare.
Hi, thank you up here. So being from Illinois, a big quote unquote like blue state, I'm concerned about how this could potentially leave smaller red states behind in this current moment that Adam Gaffney was talking about. You know, what happens if this door closes and then they have to wait? So I'd like to know, how involved were small red state SNaP members in deciding this, and what were their concerns, and what did you say to those concerns?
I'm sorry, I wasn't in what you're alluding to.
How involved were small red state SNaP members in this decision?
In what
Which
decision?
To go for state-based national health, or
Do you
state-based
mean-
Do you mean red, or do you mean like red districts or red? Because you said red states, so.
Yeah,
are you
so
talking
kind of the question of kind of alluding back to, you know, where is our energy in organizing going to? Because again, these are big liberal blue states who have a lot of that energy that could be put into getting healthcare for everyone. So my concern is, did you listen to, or like how involved were members from smaller red states in kind of, you know, for example, like the fact that we have this panel?
I'm sorry. So, so there hasn't been a formal decision by SNaP to focus on state-based legislation, if that's what you're referring to. As far as the decision to have this panel, there were no smaller groups, smaller states involved in that. I think that came from the organizers of the conference and the national board, who are mostly from New York and larger blue states. So that is a good point. But
I was just going to say it's a good point that our board is made up of 3 New York members, so definitely need to diversify so we can hear from the South.
The other thing I wanted to mention on that note is that a lot of this talk won't be relevant to you if you're in a state that hasn't expanded Medicaid, because that's a priority. Are any of you from states that haven't expanded Medicaid? Okay, so quite a few of you. Okay.
as someone from a small red state, I would just like to add that I think it is useful to hear about this, just because it's kind of inspired me, and this is more of a comment than a question, I guess. It's more of inspired me to talk to my city council members, to talk to my state elected officials, just to get the conversation going. Like, obviously, a single-payer program for Louisiana isn't going to happen. I would love that, but no. But I would love to talk to them about it and at least get it in their heads that, like, hey, your constituents actually want this. And so, yeah, although I think as a larger organization, of course, we should be advocating for the national health program, but I think this has been very useful, especially just encouraging those smaller red state members to kind of start the conversation on a more local level. Like, how can we really get involved more in the community level and with our state representatives, even if a single-payer system isn't in the foreseeable future?
Thank you, Ashley. And if you are from a red state and feel like your chapter needs more support from the national board, or if you want more resources on fighting for Medicaid expansion, please reach out to us.
Yeah, and I think it's really important for everybody else and who's here present to remember, like, if you are from a blue state who is working towards a state, or who are close to like a state single payer, if that is established, or when that is established, you don't forget about the movement towards national. Like, just, it's not our intent to become complacent in Washington once a single payer system is established and let red states kind of just wander off in their poor coverage. Our intent is to, by all means, once single payer is established in Washington, to proceed to use that as proof. Like, this is why it works. We need to make sure everyone has this kind of like plan.
So that's all the time we have for questions. Sorry, but you can catch up with these fabulous panelists after this. A small plug, you can contact students at pnhp.org if you have more questions about your chapter, or reaching out or making these connections or finding resources. So we highly encourage you to contact them. I was hoping we could get a round of applause for our fine panelists.